Thank you, Dr. Dimitri, for really setting the stage and providing the critical foundation for our day. And that really is understanding the vital role that patients can play in ensuring that our community provides patient-centered care. And we do have a lot of work to do, without question. Now, as our panelists get seated for the first panel of our day, which is aptly titled Patient Perspectives on Patient-Centered Care, I would like to introduce myself to you. I'm Trish Goldsmith. I am the Chief Executive Officer at Cancer Care, a 74-year-old advocacy organization, and we are also one of today's co-hosts for this program. I'm deeply appreciative of the Personalized Medicine Coalition, AACR, Feinstein Keene. A shout out to my dear friend Marcia Keene for allowing us to represent the voice of the patients here today. It is obviously very critical. I have the pleasure of leading an organization that each day literally directly touches the lives of hundreds of individuals. Last year, we served 180,000 individuals directly in about 89% of the counties in the US. As a cancer survivor myself, I see the struggles, the challenges, and the issues that these individuals face, not just during the course of their treatment, but long after. And I'm also blessed to have an amazing group of panelists here today that I'd like to briefly introduce you to before we get started. In alphabetical order only, our dear Rick Dickens, who is Director of Client Advocacy at Cancer Care and also a long-term lymphoma survivor. Stephanie Dunn-Haney, Stage 4 lung cancer survivor and patient advocate. Wendy Harpham, MD, who's an author, a long-term survivor, and also a patient advocate. And then Wanda Lucas, breast cancer survivor and tireless advocate as well. And Jack Whalen, research and legislative advocate, active member of AACR, and rare blood cancer survivor as well. So I'd like to start out with our panelists to pose a two-pronged question. So when I was diagnosed with cancer, I know that there were many things that went well and some things that did not go so well for me. It was challenging, it was difficult, and certainly I was not the typical patient. So what I'd like to do, and I'll start from my left and go down the row, is ask a two-pronged question of you. So think back, Rick, through your patient experience and your cancer care experience. Tell us what went well for you, but then also, can you think of one thing that if you had had the power to change, you would have done so in order to make sure that your values as a patient and a human being were respected? So Rick, we'll start with you.
What went well for me? I was diagnosed first at age 37 and was working in a corporate environment. And without a doubt, my insurance was excellent. So that's what went well for me, definitely. And I also had enough friends or knew enough people to get connected to some real good hematologists and real good treatment centers. And that was very important. Within that context, too, is, well, I'll focus just on this right now. And within that context, those were the things that were very important. When I had my first recurrence and ultimately went through an allogeneic bone marrow transplant, I had a conversion policy. And it was a very different experience in terms of healthcare. And I would prefer something was different in that way. And in some ways, I'm going to say, too, just with what's going on right now in terms of the debate about healthcare in America, it's interesting. My cancer was 25 and 21 years ago, 26 and 22 years ago. And just reading about CAPS again, or reading about pre-existing illness again, elicited some very strong feelings within me that I hadn't felt in 20-some years. And definitely I would hate to think that we might go back to something like that as a patient. In terms of what could be better, I was really fortunate again. I had difficult time with my first hematologist. He got me through that really well. But I knew that he was a difficult person to go into it, but he had a great team. And I also had access to a lot of information. And I had great friends. The first time everything went well for me, I would go back to the insurance. The second time everything went wrong for me. And ultimately, it all turned out right.
Thank you, Rick. Wendy?
Rick and I are lymphoma twins because I was 37 the same year he was diagnosed with the same cancer, follicular lymphoma. And I was a practicing internist with 3 children under 6 at the time. Over the next 17 years, I underwent 9 various courses of standard investigational and phase 1 and off-label cancer therapies. Amazingly, my last treatment was 10 years ago, and a recent checkup shows I'm in complete remission. I did have to retire from clinical medicine 3 years into my illness due to side effects, after effects, need for ongoing treatment, and I became a writer. I bring to my perspective on turning the tide is based on 3 things. One is my life as a patient. I know what it is to face recurrence. I've undergone most every test and modality of cancer therapy. As I mentioned, I've experienced side effects, after effects, and now I have new late effects that are affecting my daily life. And I experienced the terror of a terrible prognosis in '93, the hope of clinical trials, the uncertainty of remission. And I experienced it all in a dissociative way as a doctor. Something would happen or I'd feel something as a patient, and Dr. Harper would go, wow, you realize what you just thought and what you just felt. The second thing I bring to it, you said, what went wrong and what would I do different? And the only thing that went wrong with my survivorship is my lousy cancer, that it kept coming back. Because since the early days of my diagnosis, I've called myself, jokingly but not, the princess with cancer, because I had every single advantage a patient could want, except for this lousy disease. I had medical knowledge. I could communicate very effectively with my healthcare team. I knew what was going on. I could participate in the decisions. I had a devoted husband, devoted family, friends. I had great health insurance. That was never an issue. If there was a treatment that could help me, it was there. And I had deep faith. And most importantly, my doctors and nurses were not only expert, and I knew as a doctor that they were experts, they were incredibly compassionate. They got me. They got my values. I knew that if I died, it wouldn't be because I didn't get enough care or I wasn't understood. It would be because of the disease. And lastly, I bring to my perspective on turning the tide my work as a writer. One thing in particular is I write the view from the other side of the stethoscope column in Oncology Times. And anyone here who's a teacher or a writer knows you think you understand something until you try to write about it or teach it. And every single day I write and I grapple with the challenges of doctor-patient communication. I've explored all these areas that affect getting good care and living as fully as possible in a way that I never would have if I were a busy clinician. Things like hope. So 27 years later into my journey, I can tell you I'm still on the steep slope of the learning curve. I am very much looking forward to today and learning as much as I can, and I appreciate the honor of participating.
It's a real inspiration, thank you. So tell us what went right for you. What could have been better that might have reflected your values a bit more?
Sounds good, thank you. Well, first, I just want to say thank you to AACR and the whole team for giving me this platform. I'm sort of a one-man band with a big drum and a big mouth, so I'm very interested in clinical trials and advocacy and on several fronts in precision medicine. I was diagnosed with a rare incurable blood cancer about 10 years ago, and it's a pretty, normally an indolent, slow-growing cancer. Mine happened to be very fast. It's a lymphoplasmacytic lymphoma called Waldenstrom, which generally doesn't move too fast, but mine was very active, and we don't, even now we don't understand why. So in looking what the treatment options were, I met with a bright young oncologist, and she said, you know, we can try different chemotherapies from other blood cancers, sort of an empirical approach, and that just didn't make sense to me. the overall published outlook at that time was around 5 to 7 year survival based on what type of treatment you would receive. So I thought that forward-looking science made more sense. What's in clinical trials, what's not out there yet. And as you know, today, with where we are with genetics and genomics, what's in clinical trials actually may be safer and more effective than conventional chemotherapy. So I started on a path of stay away from conventional chemotherapy, tried a number of targeted therapies, and many of these drugs were phase 1, phase 2 clinical trials. And lo and behold, for me, it was the right decision. The alternative were these nuclear analogs and alkylytic agents, which mess with the bone marrow, the factory floor. And if I were to live a long time, I didn't want that to be a problem. So I chose this path of clinical trials, and I can tell you that the care was exceptionally good. When you're in clinical trials, you're monitored much more closely, much broader look at what's happening to you while you're participating in a trial. So I had absolutely no complaints. It was great. For me, it was important that I understand the biology of this cancer, try to understand how would I beat this. I was told it was rare and incurable, and it's like somebody holding a gun to your head. So that's really how I got involved in AACR. In fact, we're kind of full circle. My buddy John over there, I was crashing different conferences like the PMC at Harvard University. And I met John, and I had been doing some research on AACR, and I said, I've got to get into that program. I really need an infusion of information about blood cancers and that. And that kind of started my association with AACR. There's no secret, I'm a big fan of AACR. If I had this green color, I would paint my car this. The organization's been so good to me. You know, it's 110 years ago today that AACR was founded, and I think there were 5 physicians who got together. There was, I actually wrote down who was involved. 4 surgeons, 5 pathologists, and 2 biochemists. And Dr. Marge Foti was not there, contrary to what she sometimes says. So
she came a few years later, right?
many years later. But again, I have to plug AACR any opportunity I can. So the first diagnosis, I think, has been relatively good. It was a 10-year program. I'm still in treatment for that blood cancer. But then about a year ago, I was diagnosed with a very aggressive late-stage metastatic prostate cancer. Had all of the worst of biomarkers, a Gleason scale of 10, which is the worst number, a PSA of 250. I was metastatic in my bones and lymph nodes. And so I began, right away, I thought, well, what's in clinical trials? And the doctor said, no, there's some standard of care options that are really good for metastatic prostate cancer. So I started on these conventional chemotherapies and failed each of those. I had conventional radiation, targeted radiation, even immunotherapy, and that failed. So it was starting to look pretty bad. In fact, at the AACR annual meeting, one of my doctors said, Jack, you're not responding. It's really getting worse. And I always ask the question, well, how much time? And it really didn't look good up until perhaps the year end. And this is when you start to think, I got to start selling my stuff on eBay, or I got to get out of here. So make a long story short, part of my research involved in advocacy led me to a doctor in Germany that is doing research work in nuclear medicine. And interesting thing about prostate cancer is that there's a cell surface marker called PSMA, prostate-specific membrane antigen, that acts as a transmembrane gateway to the nucleus of the cell, and we attach to a peptide a little radioactive particle which goes in and kills the cancer. And I can tell you that this time about a month ago, I was in a wheelchair, and today I'm walking around pretty good because the tumors in my spine have shrunk. So this is a real precision medicine solution we don't tend to look at close enough, but what's happening in nuclear medicine. So anyway, I just want to keep the story short.
Thank you.
Wow.
It's interesting, a common theme we're seeing here, very inquisitive minds and individuals that are very capable of advocating for themselves. So let's move on. Stephanie, tell us about what went well for you and what didn't go so well and maybe didn't reflect your values.
Sure. It's interesting because both of those things are along kind of the same theme. Today looking back, I know that I'm very fortunate and very blessed. I was diagnosed almost now 10 years ago with stage 4 lung cancer. And that was after 2 years of looking for a source of the pain that I had in my side. Because I didn't present like a lung cancer case. I had no risk factors. So the doctors were pretty slow going to figure out what this was. So 2 years later, in 2007, they diagnosed me with stage 4 lung cancer. Have always pretty much felt good, been asymptomatic. Even now that I have, they say in the report, innumerable brain tumors, they're not presenting. They're not presenting symptoms, at least. But today I look at it that I'm very blessed. That day, when I was diagnosed, I hit the floor. It took a while to scrape me back up. And I was 39. My children were 2 and 4. I thought that the biggest thing was my children will never remember me. I will be gone in 2 years. They will never remember me. They will never know who their mother was. They won't know anything about me. Now they're, of course, 14 and 12. So the world looks a lot differently. But at that time, I had doctors. I was really depending on them. I advocate for myself, but I really trust their judgment, so it was very important that I found the right people. The folks that were closer to home at a very strong regional hospital basically said, this is incurable. They didn't tell me how much time I had, and I didn't want to know. I never ask how much time. Don't want to know. Don't want to know what they think, because I don't think that that's a question that can be answered. But they were very adamant. And I remember one doctor in particular saying, you do understand, as if I was a little naive, you understand that this is incurable, right? I said, yes, I understand. And then later saw my record and saw where he noted that. And had another doctor who was the primary oncologist, who I went in, I gave him my speech. I said, you have to understand, I have 2 young daughters at home. I have to fight this. You have to do something aggressive. I'll do anything. Just fight this as hard as you can. And he said, oh, I love fighters, and went on talking about how great it is working with fighters. The only problem is when they don't know when to stop fighting. And it took me a couple days for that to sink in and really get mad about it. Because, I just couldn't fathom. I thought that what he was telling me was, this is that time, Stephanie. You should stop fighting. And talked about a doctor I had met in Allentown that I liked very much, and he suggested out Pennsylvania. I'm from Pennsylvania. He said, I think if you want to work collaboratively with him, you should move to Allentown. Like, there was no way to work through things. No, he just didn't speak to me at all. And he was a nice man. He was a warm individual. But was kind of, well, you gotta face this. So that was very difficult, and especially with what you read about lung cancer, because based on what you read, I should be dead long ago. But on the flip side, one of my best friends is married to a radiation oncologist, and they live in South Dakota. So I couldn't go to him for care, but that was one of my first calls. What am I going to do? What does this mean? And I said, they said it's incurable. And he said a couple things. One is, he said that heart disease and diabetes are incurable too. And he said it doesn't have to be curable to be manageable. and really spoke to me in this way that helped me look at the bigger picture and how we walk down this road, and talked to me about clinical trials then. I mean, that was really my kind of initial kind of entry into thinking about clinical trials. And so that was really the good piece for me, is that he gave me sort of a goal and a way to look at this, that I could manage it, and I had some control. Because when they don't give you that at all, I think that's really lost. And I was one that I went to several doctors and met several people and wanted to find the right person. Of course, the local person was not my doctor. I ended up finding someone else a little further away. And in fact, when I went to him, he ended up saying the same things that my friend Eric said. And that's how I knew this is the man that I need to go to for my care. So finding the right doctor was particularly important. And I had both my kind of weakest, worst moments at the onset with one of those doctors, and the best moments that helped kind of set me on this journey as well.
Well stated. Thank you. Wanda, 11-year survivor.
Yes.
So tell us what went right in your journey, and what maybe didn't, and didn't reflect what was important to you.
Well, the first thing I would say is what went well was that I was able to be true to myself. I was able to rely on those tools or skills that I had, that I used in my everyday life to forge my treatment path. So I asked questions of people who had been through the breast cancer experience. I talked to my friends who were medical practitioners, and that questioning got me to the right, say, first stop, my surgeon, who really listened, answered every question that I had, and really was a partner in the process. He allowed me to rely on my faith. He didn't mind me taking my time. I knew I had great insurance. I had called my insurance company, so I had all the information that I needed to take that first step. The other thing that worked well for me was that I participated in a study during my treatment, and that study did a couple of things. It allowed me to give back to, I would say, the community, because that was the way I was raised, of being of service and giving back. And it also led me to a wonderful researcher at Georgetown who made me an advocate. She was the one that put that idea into my head and encouraged me, pushed me to my first AACR conference. So that was something I didn't foresee, but it was something that definitely worked well. I also participated in a clinical trial, another opportunity to give back and to understand what's going on and learn more about the science of breast cancer. So those things really made me happy about my treatment, being involved and having the opportunity to give back. What didn't work well for me, which really did go against my values, was that my oncologist didn't appreciate my challenging her recommendation. It wasn't that I rejected all treatment. I just decided on another course of treatment, and I felt totally disrespected. And it still bothers me all these years later that I had done my research, I had asked a question, I made another decision based on my life, and I was not respected for that. So that's what didn't work well.
5 very powerful, very different stories, some common themes here, and I think some really important lessons. What I'd like to do now is turn individually to each of our panelists and give everyone a little bit different question. And Rick, I'm going to start with you. How much do you think your care team made a difference for you with respect to your treatment and experience? And actually, how did you define your care team? And what did you consider a full care team when you think about your experience as a patient?
Good question, Trish. Thank you. For me, that was central, and it's central to a lot of the work that I do now. I would say that there were 2 care teams of sorts. there was the care team for my life, and I live in New York City. Most of my biological family was in Chicago. I belonged to a good church, and then I had this group of friends, and they were all very supportive. So I had this very solid care team for myself, for my life, which is a holistic approach to my cancer. But within the medical situation, and using very much like what Wanda said, and I didn't go into details, is that I really felt good and lucky to get into a major cancer center in New York City. I had a lot of options and was somebody who was renowned. But they had wanted me to get onto a clinical trial, a bone marrow transplant in the beginning. And not only was he upset when I didn't go for it right away, and I was 37. I was a marathon runner. I was in great shape. And to be told that you could do this, but you've got a 20, 30% chance you're not going to survive the transplant, and a 40% chance you're going to be sick the rest of your life if you do survive, just didn't make sense. And he didn't hear that or appreciate that. And I won't say what he said outside of the examining room, which just took the air out of the room and my life. I had advanced stage 4 follicular lymphoma that several people said, you've got to start doing something quickly. The care team, though, he worked with a nurse practitioner who to this day was amazing. And definitely I've had 4 oncologists in the course of my treatment. I've had 2 hematologists. I switched when I had my first stayed in the same hospital, but I switched to another hematologist who also was defined as having her own sort of characteristics, but I appreciated that and worked with that. And then when I went to a bone marrow transplant, I had a specialist there. I appreciated her team. It was the nurse practitioner the first time. It was the social worker with the second hematologist. And believe it or not, it was the phlebotomist during my transplant. And they were people who could talk to me as a person. And that's important. Now, the flip side, after 20 years now in oncology, and I was switching to social work and thinking of working in AIDS or oncology when all of this happened. After 20 years in oncology, I would say, to my surprise, and I don't know how you inculcate people who hear the words, you have cancer, and are numb emotionally and mentally in terms of what needs to happen. But there's so much pressure put on doctors to be all and everything. And recognizing doctors themselves can't, and I think that really contributes to that hierarchy, that doctors are beyond a reproach. And yet they work in a very solid team. And if somehow the rest of the patients or the patients and families could know that this is what you approach the doctor for, but there's a nurse, there's a social worker, there's other people that you could approach for resources, for emotional support, for understanding of what you're going through. And I would love to see somehow that integrated more into the earlier stages of oncology. Doctors can't be everything.
Because it does take a village.
It does take a village.
So, Wendy, you have a really unique perspective here, being both a practicing physician and a patient. So we hear a lot of discussion about informed decision-making. But I'm guessing that there may be 2 different definitions of informed decision-making. That a clinician would use and what they think would be an informed decision, and yet what informs a decisions that patients make. Could you talk about that a bit from both perspectives?
And I do have both perspectives. I remember before my diagnosis, I was very invested in educating my patients and helping them make informed medical decisions. At the time, before my diagnosis, I felt that meant making sure that patients had enough accurate information that they were able to process it so that the decisions that they made did reflect their values. My role as a doctor was communicating effectively for that individual patient. It was presenting it in a way that met that patient's style. Obviously, every patient hears things differently, so I had an obligation to get a sense of how patients hear and how they process and what matters to them. I needed to get to know them well enough to know what mattered to them. I also focused on teaching them that they had a role in this relationship, that I depended on them to ask me questions when I wasn't clear or didn't answer a question that was important to them. And lastly, I reassured them that I was not making a judgment. I didn't know the best thing for them. I wanted to help them figure out the best thing for them. And then whatever they decided, even if it was different than what I would decide for myself, I would absolutely be there for them and take care of them. This enabled me to do my best job as a doctor, because if they trusted me, they would share with me when they were doing alternative therapies or when they were not compliant with their medicines or with their physical therapy or whatever it would be, so that I could know exactly what was happening between office visits and then do my best at office visits. After my diagnosis, the first couple of weeks at home, when I was in pain, facing this diagnosis, I kept having this recurring thought in my mind as I revisited conversations with my patients where I had felt tuned into them. And I said, wow, I didn't get it. I really didn't understand what it was like to be a patient. And in the 27 years since that first diagnosis, I have come to appreciate the many factors that impact how patients hear what you tell them, even if what you tell them is accurate. And when I teach medical students and residents, I always say it matters less what you say than what patients hear. I never appreciated how much fatigue, pain, information patients get elsewhere, pressures from family, sense of responsibility impact how patients hear what you say, process what you say, and make their medical decision. If you were a fly on the wall at my visit with my oncologist during one of my recurrences, you would have thought that I was a consultant talking about another patient, because there I was with I felt physically well, and I felt pretty calm about getting good treatment, and I had my research papers, and I was just going over with him my take on these different options for my next course of treatment. At a different visit, when I'd been through 6 months of interferon, I was cachectic and underweight and weak and terrified, and my prognosis was terrible. I was just crying. I said, don't talk to me. I don't want to play any role in this decision. Just tell me what you think is best, and I will do it. Same person, different setting, different needs. So if we're going to address turning the tide of cancer care, it's not, the problem is not, for medical informed decision making, the problem is not getting information to patients. Patients are deluged with medical information. From my perspective, it's about addressing these other factors that impact how patients hear, process, and then make decisions. So, and the thing is, it's a huge challenge because every element is a moving target. Information is exploding. How patients get information is changing. And if it's okay, I wrote about this in one of my columns, and I'd just like to conclude by reading the conclusion of the column.
Sure.
It's from 2013, and the title is Time Savers. I envision future medical historians writing of how the heroes, today's heroes, 2017, tackled the tyranny of technology and reshaped the culture of modern medicine. They'll relate how your ingenuity improved EMR and other communication aids among colleagues, how you engaged smartphone apps, video teaching aids, physician extenders to facilitate the history-taking and patient education that precedes shared decision-making, how you embraced every opportunity to educate physicians in training, policymakers, and the public about the time required to take a proper history and discuss options, measures that avoid futile tests and treatments. Tomorrow's historians will highlight seminal research studies that lead to one incontrovertible conclusion: effective communication and clinical judgment based on clinicians' personal knowledge of individual patients lead to cost-effective care. Dramatic medical advances and an evolving culture of medicine are putting the squeeze on clinicians' time. By finding creative time savers for clinicians, by promoting a culture that values the time needed for high-quality care, we can continue to help patients benefit from both the miracles of modern medicine and the art, the heart of medicine.
Beautifully stated. We're running short on time, so I'm going to change it up just a bit. And for our last three panelists, one quick question and please a quick answer. What is the biggest thing that you hope to get out of today? We'll start with you, Jack.
The biggest thing, of course, is education. I'm constantly looking for new information about what's happening in life sciences and biotechnology. The other thing is I'd like to deliver a couple of very key messages that hopefully people will take home with them. And one of them could possibly save your life, and that is that if you are diagnosed with a rare or incurable disease of some kind, you really do have to look at what's available in clinical trials. We need to be active about that. Now, in the clinical trial space, there's some major problems. The biometry that we use in clinical trials is far out of date. We still process most of the information in batch mode and in retrospective mode. I'll give you an example. Before I receive the next infusion, typically they'll do a blood test, and the blood test is to determine, is this patient okay to receive this therapy? You check your creatinine for kidney function, and there's a number of biomarkers that they'll check. And then that data is used to feed back into the clinical trial system. The problem with that is by the time the data gets back to the people that are developing the therapeutics, many days, weeks, or months have gone by. And yet these new targeted medicines that we have respond sometimes, the mechanism of action responds sometimes within hours or days, but yet we're not doing anything about it. We're not
a sense of urgency is really
That's
key,
right.
and trials really key.
Yeah, exactly. Yep.
So one thing, 30 seconds or less?
Where we're headed, what's next? I think that there are so many volatile pieces out there right now, and so much potential. And so kind of wondering what's next and how it would apply to me or others like me.
Great. Last but never least, Wanda, what's your greatest hope for today?
That we discuss or become aware of how we can broaden the availability of clinical trials outside of the major cancer centers, maybe into the community oncologists, if you will.
Wonderful. Please give a round of applause for a great panel. Thank you, everyone.
Thank you so much, Trish, and all of the panelists for this great discussion, and for telling us candidly what you value in cancer care. Clearly, we need to better incorporate the perspectives of patients into cancer research and the delivery of effective patient-centered care.